So I will try in the coming minutes to discuss with you. I was unfortunately not present when some of the anemia topics were discussed earlier today, so there may be some duplication or repetition, but that's part of teaching, let's say. The optimal management of anemia nowadays. Of course, what happened the last months was that the KDIGO clinical practice guidelines for anemia and CKD were released by KDIGO. And I should mention very honestly that I'm a member of the executive committee of KDIGO. You may think this is a conflict of interest anyway. I should mention that. I will start by just mentioning very briefly, I'm sure you have heard a lot already about the TREAT study, but I think it's so important I would like to make a short summary. Second, discuss the result of the meta-analysis of hemoglobin target and outcomes. Third, discuss, again, maybe it was earlier, in as much as I can guess from the titles, the post-hoc analysis of TREAT by Solomon in New England Journal, and finally discuss the transfusion burden and towards individualization of anemia therapy. Now, TREAT, as you know, was a trial of diabetic alpha in type 2 diabetes and CKD. Inclusion criteria, I'm sure, are familiar to you. GFR between 20 and 60, type 2 diabetes, hemoglobin below 11, transferrin saturation above 15%, and no ESA agent for 12 weeks. And the patients were randomized to either a hemoglobin level of 13 or below 9 rescue therapy. And it should be mentioned that approximately half of the so-called placebo patients in fact received some darbepoetin. Now, here the classical picture from the New England Journal. As you can see, when you start darbepoetin alpha, you are able to increase rapidly hemoglobin, or reasonably rapidly, from let's say 10.4 to 12.5. And there was good separation between the two groups, the so-called placebo and the darbepoetin alpha group, even though it's still not yet clear, that may come in the coming publications, not yet still clear why the placebo group had an increase in hemoglobin over the months of the study. Is it honeymoon, so-called honeymoon, after EPO therapy? Is it a survivor bias? Is it something else? Is it partly the rescue therapy, the IV iron, the transfusions? Maybe several explanations at the same time. Now, the results of TREAT, as you know, have shown that there is no difference in the cardiovascular composite endpoint and the renal endpoint. And there were two differences: more stroke in the high hemoglobin or darbepoetin alpha group, as you know, and on the other hand, fewer cardiac revascularizations. I have no pointer to show you that, but I guess you know the picture. By the way, if someone should have a pointer, I would appreciate, because I feel without tool, I would say. Anyway, these are the figures showing the same results. Above, cardiovascular composite endpoint, left, death, fatal and non-fatal congestive heart failure, MI and myocardial ischemia, and stroke. Only a small but very significant difference in stroke below, and no difference for the other endpoints. In summary, TREAT showed was the first so-called placebo-controlled, long-term randomized controlled trial of anemia treatment in CKD. It was sponsored by Amgen and was a very well done study. There was no difference, as I mentioned, primary endpoints, death, cardiovascular event, or death ESRD between arms. No difference in individual cardiovascular endpoints except for stroke, I mentioned already. No difference in cancer death, except in those with a prior history of cancer, where there was an excess mortality in those randomized to a hemoglobin of 13, 14 deaths versus 1. There was a small but significant increase in the risk of thromboembolic arterial and venous event in the high hemoglobin group. There was a highly significant but modest improvement of quality of life in the high hemoglobin or in the darbepoetin alpha group, if you prefer. There was much more IV iron given to the placebo patients than the darbe alpha, and there were many more patients transfused. In the placebo group, 24% versus 14%, a highly significant difference. I mean, I'm sure most or all of you had already heard these results, and the summary, the treat was presented at ASN some 3 years ago now. From the treat results, of course, many investigators across the world were ready to perform meta-analysis. And there was already some months later one very good meta-analysis performed by Palmer and the group of Giovanni Stripoli from Italy. And the results show, in summary again, that there is an increased risk if you target to a higher hemoglobin. There is an increased risk of stroke, as in treat, of hypertension and vascular access thrombosis, and by contrast, no difference in the risk of mortality, cardiovascular events in general, or end-stage kidney disease. And this is mentioned on the next 3 slides, where you can see above that for all-cause mortality there is no difference. That's that point here. The same for the serious cardiovascular events below. By contrast, there is a difference for hypertension, the losange being does not crossing the vertical line, for stroke, for vascular access thrombosis above, but not for end-stage kidney disease below. And that's why the KDIGO guidelines at the onset of chapter 3 say when you initiate ESA, you should address firstly all correctable causes of anemia, including iron deficiency and inflammatory states prior to initiation of ESA therapy. That's a not graded recommendation. And second, in initiating and maintaining ESA therapy, you should balance the potential benefits of reducing blood transfusions and anemia-related symptoms against the risk of harm in individual patients, stroke, vascular access loss in those with vascular access and hypertension, and that's in line with the meta-analysis I've just shown you. For the maintenance therapy, as you probably know, the suggestion, it's not a high-level evidence, is that ESA not be used to maintain hemoglobin concentration above 11.5. Although individualization of therapy will be necessary, as some patients may have improvements in quality of life at hemoglobin concentration above 11.5, and will be prepared to accept the risk, a non-graded recommendation. And finally, the recommendation is that ESAs not be used to intentionally increase the hemoglobin concentration above 13 gram per deciliter. And that's a level 1A considered as a strong recommendation, high evidence level. The use of ESA therapy should be very cautious or with great caution in CKD patients with active malignancy, in particular when cure is the anticipated outcome. Level 1B, if they have a history of stroke, level 1B, or a history of malignancy, level 2C, less strong recommendations. And finally, the level when to start ESA therapy is somewhere around 10 gram per deciliter, or between 10 and 9, depending on the setting, CKD or hemodialysis. And these guidelines, as you know, certainly I did not mention that earlier, are freely available not only on the International Society, but also on the KDIGO website. Now, I think the most important thing we have learned in recent years about ESA therapy is this post-hoc analysis of treat. Dr. Solomon and co-workers published a paper now 2 years ago in the New England Journal performing a post-hoc analysis of the treat results. And what they did was to analyze the results of treat and define the so-called poor responders. And the poor responders, there are 4 quartiles. Even though I have no pointer, you can see that here on the left, quartile 1 is the group who had, shortly after starting ESA, in the early phase, had no change in the hemoglobin. And as you can see in that quartile, the darbepoetin alpha dose tends to be on the left higher than on those who are on the fourth quartile on the right, whereas there is the opposite for the hemoglobin. So these are indeed people who are poor responders with a relatively lower hemoglobin and a higher, oh, wonderful. That's wonderful, thank you very much. So these people have, from left to right, the hemoglobin is higher and the dosage of darbepoetin. So these are the poor responders and these are the good responders. Okay, in the early phase and in the late phase. Now, what happens is that in the late phase, the poor responders, they have an even higher dose of darbepoetin alpha, and you see the line here with the decrease from quartile to quartile of the darbepoetin dose, whereas you are able to have roughly similar hemoglobin levels between groups, but at the expense, let's say here, of higher darbepoetin dose as compared with there. Now the question is then, of course, what are the characteristics of the good responders versus the bad responders or the poor responders? And in the paper you will find that the poor responders compared to the better responders were more likely to be female, more importantly to have a history of cardiovascular disease, so a good marker of comorbidity, to be treated with aldosterone antagonist, most likely because they had congestive heart failure, to have a marginally lower serum potassium level, maybe a marker of nutrition, to have a higher CRP level, again in line with more vascular disease, more inflammation, lower ferritin and transferrin saturation level, and slightly higher BMI and less likely to smoke. No difference for age, EGFR, serum albumin level, etc. To summarize, the poor responders tended to be, if I summarize it, sicker than the other ones. That's no surprise, most likely for each of you. Now, the interesting point of the paper is that if you then look at the link between outcomes and poor responder versus good response and placebo, for the outcome of death, MI, stroke, heart failure, hospitalization for myocardial ischemia, the group with the poor response is the single group that is different from the other two. In other words, the group with the good response and the placebo group have no difference in outcome, whereas the poor initial response group has a definitely worse outcome in that respect. And the same is true for the death from any cause. Again, those with a poor response have a difference as compared with those with a good response to darbepoetin alpha and the placebo group. For stroke, the trend is less clear, and let's say the good response is in between the poor response and the placebo group. And here is the table from the same New England Journal paper. You have figures showing that. I will not discuss, but the figures I have shown are exactly the same as those in the table, and it's available on the website of the New England Journal. Now, discussion is of course extremely important. There is an evidence for an increased risk in poor responders. Is it due to the higher ESA dose? Is it due to the more severe illness? Is it due to something different than higher ESA dose, more severe illness, let's say other unmeasured confounders? Or is it due to 1 plus 2 plus 3? In other words, higher ESA dose plus comorbidity plus other confounders. Well, I think the authors have thought about that for quite a while, and they came quite rightly, in my view, with the conclusion that they don't know. Each of these explanations may play a role.